Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. It feels like we haven't chatted in quite a while.
It's been a while. I think because everybody has been so busy, we stacked a few recordings, but now here we are in the month of June.
June, that is crazy. We're recording this about a week before it's going to drop. And you know what? We've had a very mild spring, and the weather, I think, is about to take a change for St. Louis summer, but it's been delightful, other than a few minor weather blips.
Yeah, not minor, but definite weather situations in St. Louis. The weather right now is great. It's for those of you in America, it's been like in the low 60s and the low 80s, or low in the low 60s, high in the low 80s. No idea what that is in Celsius. Sorry, international folks, but very, very pleasant. Uh, Perfect swimming weather and perfect night swimming weather, which I
Uh,
enjoy after everybody's in bed.
Well, I think I've probably said this before. We also have a pool, and it kills me that it rarely gets utilized, especially with the upkeep that it requires. But it is beautiful to look at.
It is, well, that's part of my frugality is that I feel like I have to use it in order to justify the expense. And then every time a neighbor kid comes over or a friend comes over and their kid jumps in, I'm like, yes, return on investment. But you had some wise words for me when we were either that or you're trying to get me to, share the pain. When we were thinking about doing the pool, you were like, you should get the pool because your kids are of the age where you get a lot of years of use out of it, and then you'll be the house where everybody wants to come over and swim. And that has been the case so far. So you are right about that.
Still feel strongly, and then hopefully when your kids outgrow it, either you'll learn to enjoy just looking at the pool, or you'll still swim in it. We'll see.
It helps that I feed people a lot when they come over. So that's my hobby on the weekends and sometimes the weeknights.
Very, very true. I'm excited about summer. We don't have a lot of plans. I have some work travel coming up, the AOA meeting, but a couple other work trips. But what about you? Big plans for the summer?
No major work trips, fortunately. Everybody asks me where the next place I'm going is, and I have nothing to say except for Vancouver, which is in October, for the Hand Society. But that's, I think, a blessing for me. It's nice to stay put. We have a couple of family trips, but nothing crazy. So it'll be nice to enjoy the summer and, graduation's coming around for the residents and the fellows are going to be turning over before you know it. So it's in a reflective time of the year, so to say.
And it's very true. It is an interesting time when things turn over. Watching my son go through med school is also fascinating as we get daily updates on how it's going, and what gives joy to a young medical student is fascinating. I mean, it's the little things matter, and it actually is really helpful for me to see the world through his eyes,
Can
because
you
it
give an
resonates.
example? Can you give an example of that? A little thing?
Yeah, I mean, he's on OB, and the resident was kind enough to let him assist in a closure, and you would think he had just been given $1 million. And just describing the technique and throwing out knot names, which I've never heard of, it was awesome.
Yeah, we actually right now we have I didn't realize it's already visiting medical student season. So we have I one of our partners has a sub-I with him right now, and she came to my OR randomly. Somehow got thrown into a nerve case. I guess Calfee's day was done, and Dan Hong's gonna love the fact that I'm talking about a case, but not talking about him, but he was there. So this visiting med student came in, and we were doing a nerve case, and Dan was harvesting sterile nerve, and then Dan came over to help me do the micro, and I looked at the student. I was like, "Are you good at closing? Close that leg." And I don't know whether they liked it or not, but it looked beautiful at the end. So
All that matters if it looks good, for sure.
little things for the medical students. You're right. Probably shouldn't disclose this out, in public to everybody, but your Jake has been helping me with research and has been a fantastic asset to the team. And he's notched some publications recently. He just got his first Hand Society podium presentation, which is really cool.
That is fantastic. And obviously, I am grateful. I'm trying to stay out of it, but I am grateful for your mentorship. And he has been lucky enough to have some great mentors. I think he enjoys the research. I don't think it's simply a means to an end. I really don't. But as most of our listeners know, without step one of the and without grades and often without AOA and, research metrics certainly at an institution like ours matter.
I was flipping through the, I guess what we used to call the Yellow Journal, the Journal of the Academy. And one of the recent articles was talking about in the age of step two being gone, research publication projections for like when you tally like
Crazy.
publications, it was like 150 or something like that. Like that's expected for an orthopedic applicant. That's just like ridiculous. Like I'm sure it's not actually going to be that, but the message is there. It's an arms race.
The message is clear, and I don't know that it's the right message, but it's the message.
Exactly. So we have an interesting episode today. We're going to talk about a couple of listener questions, and then you've got a case to talk about, and we've got if we haven't done this in a while, an HBR article to review. So before we jump in, we should acknowledge our friends at PracticeLink. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/ the upper hand. All right, let's jump in.
All right, that's not a backslash. That's actually a slash. Like backslash is the other way.
Is that right?
Yeah,
I've been saying it this way for 5 years on the podcast with you. Now you choose to correct
yeah.
me?
I think you said slash before. Let's run the tape back. We can check.
I think I always say backslash.
Anyway, so let's talk about this case that you had. It's an interesting one that I know that a lot of people are going to really get into.
Yeah, we've talked a little bit about how one's practice develops. We when you finish your fellowship and you join a practice, or finish your training as a therapist and join a practice, you may have hopes that your practice goes in one direction, but we've talked about having an open mind on what that looks like can be beneficial. You certainly can be laser focused. I've sort of rolled with the punches a little bit. I knew I wanted to take care of kids, and one of the areas in our large practice that was not of interest to others was the pediatric slash adolescent, not backslash, slash adolescent elbow. And so I started taking care of osteochondritis dissecans and the pediatric and adolescent elbow. And that's evolved, and maybe that's a whole nother conversation. But recently, I have had several large OCDs of the capitellum. And by large, I mean over 15 millimeters in largest diameter. And that's massive, especially in a younger patient. And, microfracture of those. So, in the treatment of those,
Hold on. Before you get into
yeah.
treatment, let's backpedal. So, for those that are uninitiated, what is osteochondritis dissecans? And you probably answer this question a lot. Like, why do people get it?
Yeah, so thank you for slowing me down. So OCDs or osteochondritis dissecans represents the loss of underlying bone of the capitellum, subsequently resulting in detachment of the cartilage and usually therefore a bare area. We don't really truly know why it happens, but it's almost certainly multifactorial. There are genetics, there's a blood flow issue. Often there can be overuse, and that typically is gymnast or throwers in baseball. Um, it doesn't always make sense. The non-throwing arm can also have an OCD, so there's clearly multifactorial. Sometimes they're a nuisance, and sometimes they are fundamentally limiting to the elbow. And you get the, young athlete discussion rolls into it, which is always hard.
Is it pain? Is it catching? Is it clicking? Like, what does this present like? And then if you scan their other elbow, would they have the same thing on the other side?
Yeah, most of it is pain, especially with throwing. There can be mechanical symptoms such as clicking or locking. There can be loss of motion, especially with larger OCDs, like in this situation. And we don't routinely scan the other side, and I can't quote the exact number, but it's real, although it's low. So there, contralateral OCDs are certainly a consideration. And occasionally, I have done bilateral elbow arthroscopies just because the family wanted to deal with both. And that would be a smaller situation where you're doing what's called microfracture as part of the treatment. But yeah, it's a fascinating diagnosis, and we're sort of running through it today. But it's a big topic.
So is this the kind of thing where a lesion starts at 5, 10 millimeters, then grows to 15, or it is what it is? It's 15 from the jump.
Yeah, don't know the answer to that question. It obviously depends on the size of the affected bone. My sense is they don't necessarily get larger. So I think the answer to your question is they are what they are. Um, and then, again, there's a huge variety of how this looks, but it's a real problem. And what's interesting is not only the pathology, not only the management choices, but it's discussion with families. It's a
Hmm.
really tough one in that young athlete spectrum.
So on top of the pain, does this fast track patients towards arthritis?
Never been proven. Um, there was a recent article in a journal I don't typically read. I love how I get notifications for when I'm cited, not because I care about being cited, because it points
Subtle,
it
subtle flex.
no, it points me to articles I may want to read. And so I would say a couple
Because you've
times,
been cited in them.
but yeah, I want to see my citation in person. Um, but this one was about in this situation with OCDs, we know there can be enlargement of the radial head as a compensatory adjustment. And this article kind of looked at longer term follow-up, and actually it did show suggestions of medial elbow cartilage changes. So the answer to your question is maybe, but what's interesting is maybe arthritis develops. But what's interesting is, as someone who also takes care of young adults and et cetera, we don't see a lot of patients coming in. We don't see
Hmm.
really any patients coming in with arthritic elbows post OCD.
Right. And it's probably because and the reason they come in at the stage they come in is they can't do what they want to do.
That's right. It is interesting. We talk so much about post-traumatic changes or OCDs in the knee, for example. We've done research on the wrist, and we know that yes, intra-articular step and gap matter, and they can lead to arthritis in the wrist, but it's just not usually symptomatic. And I think the elbow probably is similar.
We talk a lot about your paper, in which I think you had to go track down patients. This was in the era where you still could like call people and go to their houses and, for research follow up. But you tracked down some patients and found that, while radiographically they have arthrosis, post-traumatic arthrosis, it doesn't necessarily correlate with any clinical symptoms. But I did finally see a patient with post-traumatic arthritis and related pain after a distal radius fracture, which I was like, wow, I thought this wasn't supposed to happen.
Yeah, I think the longer you go and the bigger the step and gap deformity, obviously it can happen. And like you, I've seen the same. I've seen asymptomatic wrist and certainly majorly symptomatic wrist. So, anyways, what's interesting about these problems is that the treatment is a lot of people like the concept of microfracture or debridement, where the theoretical goal is stimulating blood supply to the underlying bone and presumably, and it's been demonstrated, fibrocartilage develops and heals. It's not the same as native cartilage or hyaline cartilage, but in small lesions, it's absolutely good enough. The question is when is a lesion truly small, and when do you have to think about alternative treatment? There is a number of 1 centimeter diameter lesion. If it's under that, you can strongly consider microfracture, but that's still subjective. And so a lot of us really like the idea of osteochondral autografts or osteochondral allografts. And an autograft for the younger listeners is we take it from the knee, and it's a cylindrical plug, which includes cartilage on the top, bone on the bottom. And the beauty is, while cartilage won't heal, the bone-to-bone interface heals, and you have a great solution. And the patients do really well. When these lesions get really big, taking an autograft is more challenging because you're taking more normal cartilage. And so autografts are available, and I've been pretty happy with them.
So what's the I know the answer, but I'd like to hear you say it. But what's the donor site morbidity with taking a chondral plug from the knee and putting it in the elbow?
Fortunately, minimal to zero negatives in doing so. We are careful, we're very selective about where we take it from. I would say about 1 out of 10 or 1 out of 15 patients and even need therapy for their knee after an autograft harvest. And I definitely think it's the best for the patient. It's also the one that insurance companies challenge us on more and more, despite pretty strong literature. Interestingly, they don't challenge us on allograft plugs,
Oh,
even though they're
interesting.
expensive.
Really? The when you harvest the chondral graft from the knee, assuming you're taking it from a portion of the knee that doesn't see a lot of load bearing.
Yeah, some people take it from the notch, so to speak. I take it from the proximal anterolateral trochlear region. And so, yeah, almost zero contact forces. And again, seems to be really, really well tolerated. And
Does
then you
that
get
curvature typically match, from that area to where you're putting it in?
Yeah, it depends on where. Most of these are central in the capitellum. Sometimes it involves what's called the lateral wall, and you can need to adjust how you insert it. But the curvature is generally good enough, and how you insert it matters. What's funny is funny, haha, is the anxiety of, and you know this, I think, similarly with nerve autograft harvest. I don't get anxious during surgery except when I have this plug that I cannot drop no matter what. And you take the plug and grabbing the plug is fine. And then you're trying to gently manipulate it into a press fit situation.
Hmm.
And my anxiety goes through the roof and I never want to drop one of those.
Yeah. So is this all done through the scope in terms of the press fitting, or is that's a mini open or an open kind of situation?
Yeah, mini open with ankylosing split posterior laterally in the elbow and insertion. Yeah.
Yeah. So you're press fitting this thing in, and just hoping for the best it doesn't fly off the table as you're gently and more firmly then pushing it in.
I've had nightmares, yes, and nightmares in my sleep, not nightmares in the OR with dropping one of these things.
Well, I mean, I think we had an M&M probably 5 or 6 years ago at our place about an ACL graft being dropped. And I think there was one when I was a resident at a different place. So, I mean, this is something that comes up and you're terrified if it happens.
Yeah, betadine soaks and
Yeah.
all have been
So,
recommended. You just don't want to go there.
so who's harvesting the chondral plug from the knee? Is that you or a sports partner or?
Yeah, I do it. I admit that many years ago, when I first started doing this, I had the assistance of my sports partners, and we still collaborate on these cases sometimes. But generally, I'm doing it with no sports help.
uh, Through a scope, open incision?
Yeah, small parapatellar incision laterally, and yeah, I mean, it's fun going to a different part of the anatomy as you occasionally do as well.
So Dan was saying he didn't realize he signed up for a lower extremity fellowship because we're doing so much lower extremity nerve, at least probably 1 or 2 cases a week.
Is that right?
I enjoy that part of my practices, and it actually makes me relatively fearless on trauma call whenever I have to go do something. I'm pretty familiar with the anatomy in most places, which I think is the anxiety raising thing if you don't routinely operate in these other locations.
Yeah, we've talked about it. I wouldn't call it shaking it up. That sounds too, I don't know, disdainful. But it's doing something different. Brings joy, brings a little, sometimes anxiety, but I like to shaking it up for sure.
I have to pause for a second.
No problem.
We had a tooth fairy situation, put a fire
Oh,
out really quickly.
yeah. Sometimes you got to go dig behind the bed to find the fairy money.
It's a cashless society, bro.
True. We didn't have those problems.
Where did we leave off with your case?
Jesus, I probably should know. Um, no, no, just say, well, let's cut to the chase. What'd you do? And then I'll
Yeah, so how did you oh wait. So how'd you end up managing this one? Was and press fitted and you said it was a 15 millimeter defect?
Yeah, so I have a handful of these. Actually, I thought about at some point whether it'd be useful to share our findings and results. But so this was a large lesion. When you order allograft plugs, you can get 12 millimeter plugs, and they come in a set of two. And so we end up using both plugs and sort of what they call snowmanning them together. And
Venn
you
diagram kind of situation?
Venn diagram nicely. That's probably a little more
It's not a snowman if
sophisticated.
they're the same size. Like what kind of snowman is like
True, true. And you sound more intelligent when you say Venn diagram rather than snowman, but
MasterCard logo? I mean,
it's my sports colleagues. I'm using their terminology. So,
snowman. I wouldn't trust them to build a snowman.
um, yeah. And then you don't splint them. I put a soft dressing on, let them start moving. And of course, limit their activities. But hopefully about 3 to 4 months, they're healed and they're back to activities, which is a whole nother discussion.
So if you're Venn diagramming these things, does that mean you then have to make your defect match the geometry of your snowman Venn diagrammed allografts?
No, you sort of just how much you overlap the interlocking circles, is affected by what you have. And you can microfracture around them. So you're just trying to get the best possible fit. And kind of fun to figure it out. And then it's also kind of fun when you put the first plug in and you're patting yourself on the back. It's not on the floor, it's in the patient. Great job. And then you take a massive reamer and then you ream the new hole and you take part of the beautiful plug you just put in, your word is going to spin out. So I'm living like a sports surgeon a little bit.
Man, that's crazy. So then how much of it do you think is the actual plug versus the reaming? Because you mentioned the underlying theory for microfracture.
I think it's both. I think it's both. I think the plugs survive and do a good job. And second look operations in the knee certainly confirm that
And then you went to allograft for this one because of the size of the
because of the
defect.
size. Yeah, because of the
What's your
size.
threshold for auto versus allo?
It's a great question that I do not have a good enough answer for. Typically, if I'm doing probably a 9, 10, or 11 millimeter plug, I'll use auto, assuming I can get insurance approval. And if it's bigger, I use allograft.
Okay. Well, thanks for sharing that case. I'm sure there'll be an eager resident or fellow coming in soon that wants to write up your case series. That'd be great.
As Dr. Governman used to say, which I didn't appreciate at the time, if only we had an eager resident or fellow.
I use that line all the time. I still use it.
It's great.
You have to be careful with what you try to shame people into, though. It's got to be something really good. I've given some projects, just ideas out there that haven't panned out. Let's put it that way.
Absolutely. Hey, Chris, should we thank our other important sponsor?
Yes, this podcast is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Join Checkpoint in Las Vegas on October 25th and 26th for an advanced course on treating spasticity from the elbow to the fingers. Hosted by Checkpoint Surgical and led by expert faculty Doctors Peter Ree, Kyle Chepla, and Kitty Wu, this course focuses on integrating nerve-based procedures like selective and hyperselective neurectomy into your surgical practice.
Are you sure you want me to read? You left me like one small sentence.
I
Which
just kept I just kept going. I wanted to talk. I wanted to say hyperselective neurectomy.
I know I like saying that too, even though I don't do it. With lectures, cadaveric dissections, interactive discussions designed for practicing hand surgeons and fellows. Register now at nervemaster.com. And that is the week after the Hand Society. Interesting.
Man, if Vancouver wasn't enough, you can go to Las Vegas, have a good time there. You could do anything in Las Vegas because they have everything in the world there.
They definitely do. Wow, time is flying. I definitely want to talk about this HBR article, but is it time for that?
Yeah, I think it's probably time to. We should ask this one question because a fan of the podcast is Trip Levitt, who practices at Geisinger, and he wrote in asking about. We talked about whether or not we get x-rays for thumb CMC arthritis. And we typically don't. But what about in younger patients? Actually, interestingly enough, saw a younger patient who has thumb CMC arthritis, and she was my age, and I didn't realize that until right after. She's like, "I'm really young for arthritis." I was like, "Just some people get it a little bit younger." And I walked out. I looked at her chart. I was like, "Ooh, same age." So, what do you think of this patient in their 40s, for example? Do you think of them any differently than the patient in their 50s? And are you either treating them differently? Are you getting X-rays earlier? That's part one of Trip's email.
Yeah, the email's a really good topic, and I would say that we all recognize that you're not so young anymore, Chris, and 40 is in the realm of arthritis. It's definitely young. And I'm in my 50s. I'm in my 50s. Should we share why you're holding the money? I guess we can't right now.
Evelina, can you hold on? Let me get you on speaker here so that you can hear yourself. So, Evie, why are you flashing dollar bills on this podcast right now?
What happened yesterday or last night?
Yesterday, I was walking across the street. In the middle of the street, it just popped out.
Oh my goodness. Evelina lost a tooth, and it seems the tooth fairy has made an appearance. And wow,
But
inflation. She's still explaining because I can't hear her.
You have to speak into the microphone if you want people to hear you.
this summer too. But then I checked my grandparents' place where they're sleeping, which was my room, and I found $5.
Okay,
Wow.
okay, guys.
Sorry, Chuck.
No problem.
Rafi wants to say one thing.
Tell me. That's some question.
Well, tell Uncle Chuck about your hat. Now
No.
maybe we'll get a sponsorship from Waggle.
Oh, nice. Let's see it. That is awesome. I
These
love
are
that
Awesome.
all the rage among 9 to 10-year-old boys.
for sure.
9 to 10.
Okay. All right. I have to finish up, guys.
All right, I have to finish up, guys.
They're not golf hats. They are golf hats,
Well,
but they're actually worn by many hockey players. I guess the next time the answer is yes, earlier on the recording.
I'm not sure if I'm going to keep all that or cut it all
Got it.
out.
Got it.
Okay.
Actually send me the video so I have it. I
Well,
can show them later.
I'm not editing the video, so it's going to be
Yeah.
uploaded as is.
Good.
It'll be funny. It'll be funny.
So you were saying I guess you were just saying about patients in their 40s and 50s.
Yeah. So patients in their 40s, obviously young, but certainly may have arthritis. I think the younger 40s and the patients in their 30s without X-ray evidence of arthritis are super interesting. And so in those patients, I am far more likely to get an X-ray. When you can see the deformity and you know there's arthritis, it still can be helpful to document with an X-ray, even though I don't think it changes a darn thing. We know that pain doesn't correlate with X-ray changes. It's just not that helpful. But in a 35-year-old or in a 40-year-old, yes, I get X-rays. And sometimes even advanced imaging, I guess, is the first answer.
Now, so if it's in the context of ligamentous laxity, does that change things for you? Because that is typically where I would see this in younger patients, as well as what Tripp noticed in his emails as well, is that the ligamentously lax population tends to just behave a little differently than the run-of-the-mill wear and tear osteoarthritis population.
For sure. This is a super interesting and super, I would say, not straightforward situation. And so you really want to understand whether this is ligamentous laxity pain, early arthritis, which is not visible on x-rays, and how do you manage it? And I would say for these patients, I send them all to therapy to start. And I give, I don't think splinting's the answer, but splinting can be a helpful modality. I think strengthening the thenar and muscles around the joint can be helpful, and certainly want to do everything in our power to avoid the need for surgery. But if ligamentous laxity is truly the issue, surgery might be the answer.
And I guess before we jump it, we could talk about that. But in the younger patient, either the ligaments lax or the patient with early arthritis or happens to be younger, Trip mentions potentially not including the lidocaine mixed to the injectate. Uh, Most of us will do a little bit of lidocaine or marcaine as a local anesthetic combined with the steroid of choice for the thought of helping with post-injection pain. But some of these local anesthetics have been demonstrated to be chondrotoxic.
It's a really, really interesting point that I very much appreciate. There was a recent article out of Indiana, which you may have seen. Is it in the Journal of Hand Surgery? I don't remember which journal it was in, but basically said we don't need to use lidocaine for trigger injections. And it's a more important point for joint injections in a young patient. But I think it's valid. I think it's absolutely reasonable.
Do you think that the lidocaine actually makes a difference in terms of pain? Or it's just that you're telling somebody, oh, I'm putting some pain medication in there with the steroid.
Every patient wants something, right? They want the cold spray, which slows you down, or they want an injection. I think it helps the patient in the short term see some early results and give them confidence they'll see delayed results. Does it? I don't believe it fundamentally changes anything.
Yes, I think how much of this is because for the show, also for workflow considerations. I remember Dr. Gelberman used to do two separate injections, which just absolutely slows things down from a assistant perspective and from your perspective. But hey,
Yeah.
people were really happy with that. I still get people asking for the Gelberman injection.
Yeah, the two injections. Maybe we should touch on this on another episode, but if you have a patient with generalized ligamentous laxity and pain localized to the CMC joint, it is a really tough situation. Because the thought that therapy might help their pain, I don't think that's valid. I don't think in the long run it's likely to help most people. And yet, you also don't want to go down the road of offering surgery for all of these kind of considerations.
So in the context of thumb CMC arthritis, I mean the solution theoretically surgically would be an eat and reconstruction, right?
For
Unless you have
some,
something else to offer.
I definitely do.
Oh, capsulorrhaphy, right?
Heat shrinkage.
Yeah. Okay.
Yeah. So, I do believe in CMC arthroscopy. I think it's pretty straightforward and I think it's definitely enjoyable. And I think the fellows like to see it. It does give me information about the presence or absence of any arthritis. It does open the door. If you have limited arthritis, you can do a closing wedge osteotomy of the base of the metacarpal. And then I believe in heat shrinkage in these situations. We've talked about it before, but heat shrinkage got a bad rap when it was used for the shoulder because you cannot immobilize the shoulder, but you can immobilize the wrist, you can immobilize the CMC, and if you give it 6 weeks, I think it matters. I think it helps.
I admit I don't know the evidence base so far for thermal capsulorrhaphy in the context of thumb CMC. Is this something that's widely done? Is this something that is more on the anecdotal level?
It's not widely done. It's a little more than anecdotal, but you're right. The science is not there to guide us and give us reasonable expectations.
I
So
look
it's
forward to
level
you.
5.
I was say I look forward to you receiving a notification on your from people citing your podcast commentary, level 5 plus.
We will have made it when people cite us in the podcast.
I almost
Uh,
did thinking about I was writing up something for a grant and I couldn't find the exact citation. I almost just wrote in a citation for the pod, but I did not. I found
yeah,
the citation
that would have gone over really well. Really well.
if they even noticed.
True. Um, yeah, so interesting question, unsolved problem. I think these young patients with potential arthritis versus potential laxity are super tricky. It's easier in an 18-year-old. In an 18-year-old, they get an Eaton ligamentous reconstruction with a hemi or complete FCR. But in older patients, it's trickier for sure.
Um, Maybe in a future episode you can talk us through how you do your Eaton and how it may vary technically from a standard LRTI, because I found that to be it's a challenging surgery to do because the trapezium's in the way.
Yeah, I think that actually would be a good conversation when we could roll in arthroscopic treatment of the CMC as well. That would be fun. Let's do that. We'll
People
put it
love
on the list.
CMC. Yeah, put it on the list. So, Trip, thank you for the question. If there are more questions, please feel free to email them handpodcast@gmail.com. Trip, I'm sorry it took a little bit of time to get to your question, but I hope that this has been helpful for you, but it's been helpful for us to have the question. So, thanks.
For sure. So let's close with a brief, probably briefer than it deserves, but a brief conversation about one of the seminal articles in the Harvard Business Review on leadership.
So, was this article part of your MBA curriculum?
This article was not. I've tried to do a couple of things to not just let the MBA, slowly escape from my brain. And so I do subscribe to HBR. I do try to read the articles, and it does come up in my administrative role regularly. And I think it's the information out there is a great resource. And I don't know how I came across this article, but it's really good.
It is a really good one. It's in the best of HBR. This is an article from December of 2001, which I should to double check the date when I saw that initially. I'd love to see if you think it ages well, but it's called The Work of Leadership. It's by Ronald Heifetz and Donald Laurie. I'm hoping we can put the HBR code into the show notes for people to check it out. But Chuck, why don't you introduce this and then like I said, I was texted you last night as I was reading it. I said, maybe I'll let you steer this conversation because it's a pretty interesting article, especially in the current context of where we are right now.
Well, and that's why I think it's so interesting. Actually, I am giving a talk at the AOA meeting this coming week, and I actually include a citation to this article. Basically, the fundamental issue is, there's all kind of leadership paradigms, and we could go through them, but I don't think that's the point of this discussion, maybe a future episode. But in this article, they discuss two types of challenges. One, which is the more common, is a technical challenge. And that's where leadership can identify a problem and figure out concrete steps to tackle that problem. And that's what we all enjoy because these are solvable problems, right? And that can be big leadership, little leadership, clinic leadership, right? I mean, that resonates, doesn't it?
I think it does, for sure. I mean, but that's the stuff that you think about more routinely as the easier problems. But I think maybe the second type of problem you're going to describe is just this kind of time where you have to change culture when you have bigger problems to grapple with.
Yes. And so it resonates with you and I sitting in an academic medical center, potentially confronted with unbelievable challenges that really are not technical problems. And so these are been referenced as adaptive challenges. And these to solve these issues, you have to think differently, you have to innovate, you have to change your culture, change your values. Um, and it just requires more of a fundamental shift. And I feel like that's what we're confronting today in 2025.
Yeah, so to put it more concretely, I mean, academic medical center in the U.S. in which you have an administration that is fundamentally changing how the funding streams for academic centers. So potential cuts to federal fund for research grants, the indirect expenses that come with those grants. So in a lot of places, you're going to see cuts of 2x, 3x to the funds attached to the grants. So that's the stuff that's not going to the actual investigator, but to the medical school to pay for the infrastructure. You're seeing cuts in that. You're seeing cuts in different healthcare programs, way healthcare is funded. For example, Medicaid, which is a big funder for the hospital and for the providers, better for the hospital than the providers, but still a large chunk of money. And those are just two examples, two things that are in jeopardy right now in the states, in threatening a lot of major academic institutions.
That's exactly right, and there are more. I mean,
Yeah.
we could maybe a good episode to talk about this kind of stuff. It really gets into economics of healthcare, especially for those of us in academics. But all of this stuff affects every provider out there, even if it's a little less direct. And so we're sitting in this situation where we are the classic expression is that if you don't have profitability, then where does your mission go? So no margin, no mission.
Hmm.
And our margin has absolutely been threatened, and it's going to continue to be threatened. So the fundamental thought is this is an adaptive challenge, which requires adaptive leadership.
So I'll ask you to define that term. I like the way that they introduce this article because that clearly relates to us in healthcare. They talk about somebody who has a triple bypass surgery, and then they're told, all right, well, now I've given you a tool. I've given you a triple bypass, but now you have to change the way you eat, change the way you live. You have to exercise more. You have skin in the game now. And I think we all understand that example as surgeons, therapists, et cetera. Like people thank me for the result. I'm like, I did my part. Okay. Now you have to do the therapy. Now you have to change these certain things to get the best out of the surgery. And I think one of the things that struck me about this article is how much this adaptive leadership involves getting the people being led, the team, to actually do more. And I wanted to ask you about that because I mean, in your role as the executive vice chair of a department, in your admin and leadership roles, seems like you're saying we need to ask more of the people that you're leading.
Well, it's certainly not, there's no leadership mandate that's going to roll down to our department of 750 people. We have to, first of all, as the landscape changes, we have to understand what's changing. That's number one. And so in the article, they call this get on the balcony. And so you gotta get above the fray. And you think about, I'm a history buff, and you think about leadership and what used to happen in the olden days. And the leaders would sit on the hill overseeing kind of what's going on so they didn't get caught up in the fray. And so get on the balcony and identify the challenge. Like that's what they really understand what the challenge is because that'll inform um, basic strategies to start. And
But
then,
they did say that on top of, in addition to getting on the balcony, you need to get into the fray. And you
yeah,
need to talk to, for this example, they use British Airways, how they had a huge culture issue in the 90s. And then they had to just get down to baggage handlers, reservation centers, and just talk to people about the problems. Because I think when you stay above the fray and you're, calling the plays from the press box, so to say, like you're not understanding what's going on the ground as well.
yeah, and that's exactly right. You have to understand the adaptive challenge. You have to make sure your people understand that there is this huge challenge, but you got to keep things under control and listen. So first you have to understand, and then as I think we all appreciate, there are problem solvers everywhere, and the baggage handlers in the example you give are probably the ones that can figure out how to help you solve problems. Like they may be doing their job, but recognize there's a better way to do the job. And so that's an example of listen, because that will inform decision making.
So the next step they talk about is regulating distress. So how do you think about that, either in the context of this article or in your day to day?
Yeah, I mean, I would say that there's a lot of, I think there is a lot of distress in our department. There's been messaging from the chancellor, messaging from the dean, and so I think this is absolutely relevant to what we are discussing. And I think from our perspective, we just want to be honest, and we want people to understand that we are going to do everything we can to protect the mission, and we want to, continue to provide great patient care. And I also think it's important to focus on what the distress part we can't eliminate, but we want people to focus on what we do, what each of us do every day, because that matters. And if we can focus on that, some of the distress, I hope, will fall out. So provide direction, provide support for why we come to work every day. That's certainly part of it for me.
And I think one of the interesting things here is just navigating that tension of asking people are in distress and they want to be led and they want to be led through an issue, but then you're putting work back on them. I'm not necessarily saying you're asking them to do more, but you're asking them to work either in a different way or at a different volume. How do you navigate that tension?
I think hopefully with the right leadership style, hopefully it navigates itself. I think, the tension that we have, I'm bringing it back to our current adaptive challenges. We all understand we've been asked to work harder to sort of help mitigate some of the challenges. So we all understand that there is a real challenge. And so not only do we have to do what we normally do, but we have to think differently. And I hope, and I do honestly believe that people get that. And so we want to focus on the problem. We know we don't want to lose our attention to the problem, but we also want everyone to understand they're part of the solution. There's no simple answer that's going to roll downhill from the chancellor, from the dean, from the department chair. This is going to take all of us to sort of figure out what's next.
So, can you think of an example in healthcare outside of this patient context where this adaptive leadership style has proven beneficial? And maybe there isn't one, but can you think of another example aside from what we're going through right now?
Well, I was actually going to say, and it's a great question. I actually was going to turn it back to our patient, the elbow patient we discussed. I mean, it's sort of similar to the cardiac example, but so we're going in and we're doing these allograft plugs, and yet we need the family to understand that the surgical answer doesn't solve the problem. In all likelihood, they are going to have to adjust how their family addresses this issue. And so, from a very patient focused level, it's a similar example to cardiac. Um, I will say that, and I've used this example before, but a big picture healthcare is I don't think the cardiac surgeons 50 years ago, is that right? 40 years ago, understood the challenge that existed from cardiology and the work they were doing around the heart. And so cardiac surgeons thought, yeah, the cardiologists may be able to do some things minimally invasively, but we're the cardiac surgeons and we will keep doing cabbages for 100 more years. And they did not adapt to that challenge.
Yeah, there was a great cardiothoracic surgery lecture every year for like the second year medical students in my medical school. Described exactly how the CT surgeons missed the boat and did not adapt to that challenge. So yes, I think that there probably are some additional ways in which adaptive leadership is useful. I think anybody that's been a residency director probably thinks that and this is the challenge is that you have to have everybody have skin in the game to make the residency better. But the residents, and I'm not saying our residents here, I'm just saying in general, most places, the residents aren't going to want to do more to make the program better, and they're just waiting for somebody to save the program. And I think that's the biggest challenge is, I think that's the perfect context to see in which this leadership style may or may not work is if you can find the ability to implement adaptive leadership in those sort of contexts.
Yeah, it's a good example I didn't initially think of. So basically, while some may argue that the residency paradigm continues to be an adaptive challenge, fundamentally it started with the implementation of the 80-hour work week. That was the fundamental change in putting our heads down and saying this is a technical challenge, which it kind of is, but it is more than a technical challenge on how to provide the same level of patient care, provide the same level of education while adapting to a fundamental kind of change to the world we have all lived in.
I mean, to bring it to a close, I mean, I argue that the 80-hour work week was the technical challenge, and the adaptive challenge is the fact that, or the cultural challenge is the fact that culture has shifted generationally. The way people want to work and the way people want to view their job and view residency is different now. And you can bemoan, the changes and talk about the good old days, but it doesn't matter. It is what it is right now. You either get with the program or not.
Yeah, I think that's true. I totally agree with you. I think the 80-hour work week was the first bell, so to speak, of a
Right.
change. And it was sort of technical, but I think it's so complex and so interesting. And again, no easy answers.
Well, I hope people and check out this article, and hopefully they found the conversation useful. Please let us know if there are other things you want to discuss, us to discuss on the pod. I've got more sports coming apparently, more Thumb CMC. But write us handpodcast@gmail.com and please leave a review. We have a couple new reviews that we'll share during our next episode.
It's been fun.
All right, thanks a lot. Have a good day.
Thank you. Where's the stop?